Good afternoon. This is Jose Enriquez, student, FNP student at U.S. University, FNP class 596 with Dr. Orelus. And I am going to be presenting this case study, pulmonary complaint in a geriatric patient with occupational exposure. The patient came in a couple of weeks ago. His initials are RJ. And he is a 74-year-old male. He came in around the 21st, 22nd of October. He's to Beacon Health Care Clinic in Edinburgh, Texas. The providers were Lisa Bloom, NP, my preceptor, myself, and then Dr. Nofke also concurred with the final diagnosis. His chief complaint that he stated upon arrival said, I have been having a lot of congestion and shortness of breath that's been getting worse over the last few months. I did a quick history on him, and it found out that he presents with a progressive cough that has been getting worse and worse over the last few months, especially it's something called exertional dyspnea. Whenever he walks long distances or goes upstairs, he complains of shortness of breath. The symptoms are getting worse, are usually worse in the morning and late evenings, and he describes the cough as very dry, but occasionally is somewhat productive with clear sputum. He denies any chest pain at this time. He denied hemoptysis, blood in the sputum, any fever or weight loss. And then he also reported that his breathing had become more difficult upon, like I said, walking long distances, whereas before he didn't have that problem. Furthermore, in the history taking, I discovered that he had been a 30-year employee of a petroleum refinery company, a chemical refinery company there in Brownsville, Texas, and where he had been exposed to many solvents, hydrocarbons, and particulate fumes. He reports that he never used any type of protective respiratory protection for the first 20 years. However, the last 10 years he was required to because OSHA came in and changed the policies there. And then, so there's no recent history of any type of infections as well. He hasn't done any international traveling, and exposure to tuberculosis he denies. He did state that he had quit 15 years ago of smoking. He had smoked for 30-pack years, and however, he sometimes is tempted to go back, but he realizes that's not going to help the situation. On his past medical history, we discovered that he has a history of hypertension, diagnosed in 2001. He is a type 2 diabetic, diagnosed around 2010. It is well controlled with medications. He has a history of hyperlipidemia, also very well controlled. And like I said, he is a former smoker, 30-pack years. When it came to surgical history, we discovered that he had a childhood appendectomy. He claims he was around 15 years of age at the time, but couldn't remember if he was the exact year. And in 2018, he had a right knee arthroscopy done for some sort of inflammation to the knee. And when it came to family history, his father is deceased. He passed at the age of 69 from lung cancer. When it comes to his mother, she is also deceased, and she passed at the age of 80 with congestive heart failure. When it comes to social history, we discovered that he is, like I said, retired petroleum plant worker. He lives with his wife. No alcohol or illicit drug use is being used at this time. And like I said, he did quit smoking in around the year 2010. In the review of systems, he does have a general male appearance, no fever, chills, or weight loss noted at this time. He did have mild nasal congestion upon inspection. Respiratory-wise, we noticed that every now and then he did have a little cough. Also, he had dyspnea upon exertion, talking for long periods of time. However, we did not find any wheezing or hemoptysis during the time of consultation. The cardiovascular, we showed no chest pain or on palpitations at this time. And gastrointestinal, he denies any reflux or dysphagia. Musculoskeletal system, he denies any joint pain. And when it came to skin, there were no cyanosis at present or any clubbing noted, and his cap refills were less than 2 seconds. Neurologically wise, there was no dizziness or syncope that he claimed that at this present time. However, on his vital signs, we did notice a couple of things. Even though his blood pressure was controlled at 132/76, his heart rate was at 88 beats per minute. Respiratory rate was 22 breaths per minute, and temperature was right on the money at 98.6 Fahrenheit. His room air was 91, and I noticed that he would stop and try to catch his breath every now and then. His BMI was around 27.4 kilograms per meter squared. Like I said, his general overall appearance was elderly male. He did appear somewhat dyspneic after speaking long periods of time with us. His lungs, we found that he had somewhat bibasilar inspiratory crackles. That are sometimes called Velcro rails. There was no wheezing, but we noticed that at the bases of his lungs, he didn't have any air movement. So we very much diminished bases at the lower lobes. When it came to the cardiac, his rate was regular. His rhythm had no irregularity, no murmurs or gallops were found. His abdomen was soft and non-tender, no hepato or splenomegaly at the present. When it came to his extremities, there was no edema, no clubbing or cyanosis, like I stated before. We did not find any of that, and his skin was normal turgor, no lesions. However, when we started discussing the possible differential diagnoses, there was quite a few that came up. Because of his exposure to environmental antigens, the first and foremost was the idiopathic pulmonary fibrosis. It was likely secondary to long-term occupational exposure to petroleum and chemical agents. That was at the top of the list. Secondarily, we came up with chronic obstructive pulmonary disease, COPD, and this was possibly due to him smoking for 30 years. Thirdly, we said he could have also chronic bronchitis, given that he is having cough and congestion. Fourth, we also decided that because of his exposure at the chemical plant, it could be asbestosis or silicosis, possibly due to the inorganic dust particles that he was exposed for 30 years. And lastly, number 5, we came up with hypersensitivity pneumonitis, which is less likely but should be considered because of the exposure again to all the chemical particulates at the chemical plant. However, the final diagnosis that we finally determined was to be occupational pulmonary fibrosis, secondary to long-term petroleum chemical exposure. So our plan to educate him was to refer him for quite a few things. Subjectively, first of all, because of his chronic congestion and his progressive dyspnea and cough, there is significant occupational exposure in this individual. We referred him because he also had bibasilar crackles, reduced oxygen at 91%, and pulmonary changes consistent with fibrotic changes. And these findings support a diagnosis of fibrosis. So we referred him for imaging. We wanted him to go get a high-resolution CT scan to evaluate any fibrotic changes and any possible patterns called honeycombing. And so we're going to wait and see him later to see what the images results return. Secondarily, we also referred him to Pulmonary for rehabilitation, and this will provide breathing exercises and physical conditioning to improve function and quality of life. Thirdly, we also are going to recommend an evaluation for home oxygen supplementation if desaturation continues anything below 88, especially with exertion. Number 4, we also educated him about environmental precautions, avoid exposure to smoke, fumes, and other irritants. Number 5, we also made sure that he was up to date on his vaccinations, especially influenza and pneumococcal vaccinations, to reduce the risk of respiratory infections. Number 6, we also educated him on the disease course. What is fibrosis and what was the cause of it? We also told him how to manage his symptoms with proper education, rest, proper nutrition, and to not consider returning to smoking. We also provided him literature on resources for pulmonary support groups. And lastly, we set up a follow-up return visit for 4 weeks for another clinical reassessment and to review the imaging results. So my final clinical impressions on this case is that this patient's presentation is consistent with fibrotic lung disease associated with chronic exposure to petroleum-based chemical compounds. Studies show that occupational exposure to hydrocarbons and other industrial chemicals increases the risk of interstitial lung disease and pulmonary fibrosis due to chronic inflammatory and oxidative injury. And this comes from Kim et al. 2020 and Kruder et al. 2021. Early pulmonary rehabilitation and supportive therapy can slow the disease progression and improve the quality of life. And this comes from Ragu et al. 2022. So we will wait. He should return in a couple of weeks, and we should see the results of the imaging to see if there is any fibrotic changes, and we will continue with his care. This concludes my presentation on RJ, 74-year-old geriatric patient with occupational exposure and pulmonary complaints. Thank you. This is Jose Enriquez.